Thank you and good afternoon, everyone. So today we're going to be focusing on low back pain, one of the things that is deep into my subspecialty of interventional pain medicine. We're going to be talking about the causes of low back pain, the general anatomy, the treatments that we do for it, and then obviously Dr. Chin will take off from there and be talking about the things that can predispose you to some of the low back pain that I'll touch lightly, but she'll get into in a lot more detail. So without further ado, let's dig right in. First, a little bit about me. I was born in Tampa. I grew up in St. Augustine, Florida, so I've bounced around the state a little bit. I am a true Gator through and through. I grew up going to Gator games, go Gators. Went to undergrad here. Went to medical school down in Boca Raton, Florida, at Florida Atlantic University, and then Fort Lauderdale. Did my residency and my fellowship training in Birmingham, Alabama, and then proudly returned right to Gainesville. This is my family. You can see we spent Easter at the beach. I have 3 young kids. I had 3 under 3 for a while there. That was an adventure, but we've made it to today. So let's dig in. Low back pain. If you have low back pain, you are most certainly not alone. 8 in 10 Americans will experience low back pain during their lifetime. That is a high number, obviously. The reason that that number is so high is because that is a very broad definition of low back pain. That could be, oh, I twinged my back and it hurt for a week. That could be, I hurt my back when I was 18, now I'm 88, and I've had 70 years of low back pain. But almost everyone will deal with low back pain over the course of their life. 619 million people around the world are affected by low back pain. We'll get into that number on the next slide a little bit more detail. And then 5% of those acute low back pains, oh, I twinged my back, oh, I pulled a muscle, oh, my back just hurt when I woke up this morning, will turn into a chronic back pain. That chronic back pain means over 3 months. Usually, once we get to that 3 months or longer, we're going to be dealing with a more long-term picture for low back pain. $635 billion is the annual cost of the U.S. economy for low back pain treatment. It's one of the most common things that people come to their primary care for. Depending on the study that you look at and the kind of surveys that they take, it's anywhere from 2nd to about 5th for the reasons that people come into their doctor. Primary care specifically is what I mean by that. That includes well visits, that includes annual checkups, sniffles. That's everything that people come to the doctor for. It's the number 4 is kind of the most common number that you see reason for people to come in. Like I said, that 619 million cases of low back pain worldwide was in 2020. That's up 60% from 1990. We'll get into the risk factors for low back pain and likely why that number has gone up the way that it has. But you can see, and even since 2020, I would bet $1 that it has gone up even more at this point because it's been 5 years and those numbers continue to rise. The risk factors for low back pain. This is a complicated looking graph, but really what I want you to know is at the bottom here is 5-year increments. So from 1 to 4 all the way up to 90 to 94 over here, this is the number of low back pain visits that we see. You can see this middle line is the 50 to 54, so that's the most common age to have that initial low back pain diagnosis. And then as you accumulate birthdays, the more birthdays you have, the higher the risk of you having low back pain, which makes sense because the longer you live, the more likely you're going to have an incident of low back pain. But as you get all the way up to this 80 to 84, that's the highest, the most percentage of folks will have low back pain at that point. Other risk factors for low back pain. The accumulation of birthdays, like I said, is the highest risk factor, but obesity is really a close second. The higher the BMI or the body mass index, the more obese a person is, the more likely they are to have low back pain. We'll get into this underweight category a little bit as well. That'll mostly be in the second lecture today because as you get underweight and older, frankly, osteoporosis becomes a real risk, and that can be a back pain risk factor as well. Another huge risk factor is smoking. This can be both tobacco smoking and marijuana smoking. That is something that's come out recently. All of those medical marijuana places that cater to back pain, the newer studies are showing smoking tobacco alone increases the risk of low back pain. Smoking marijuana alone increases the risk of low back pain. Smoking both marijuana and tobacco exponentially raises that. They work synergistically. So any type of smoking is going to increase the risk of low back pain. The reason behind that is thought to be a systemic inflammation. So whenever you smoke, it increases the inflammatory markers in your body. It also decreases blood flow. It constricts the blood vessels, so you're not able to get all of those healing factors to the areas where they need to go. Another risk factor is bad posture, which I just think this is a really fun exaggeration of. Not to say I haven't seen patients in my clinic that have a very similar posture to that when they come in, but also a stressful job and low job satisfaction are high risk factors for this. The stress is thought to basically do a similar thing. It increases the inflammation in your body. Anybody here working with jackhammers or construction currently? Okay. So that is high vibratory jobs. So working with a jackhammer or a similar setup where maybe you're driving on rough roads, anything that causes a consistent vibration increases the risk, especially of radicular pain or pain coming from the back going down the legs, the classic kind of sciatica pain that we see a lot of our folks in the clinic for. Depression, anxiety, high stress environments, it kind of follows with the high stress work environment, but those really emotional or psychological factors are going to be a risk factor as well. It's shown to be a direct through line. Low, basically, life satisfaction rates. There are surveys that measure that specifically, and folks who score low on those surveys have a higher incidence of generalized pain, but especially of low back pain. The things that can protect you from this low back pain. The really large studies show that walking and biking, they specify in the studies walking and biking to work, but in general, just walking, biking, keeping active, and getting around of your own power is a really high protective factor for low back pain. It decreases the risk. It's one of the highest decreases in risk that you can have. Keeping that core strong. So whenever you think of someone in a back brace, you know they wrap around and it creates this tension right here that's supposed to help decrease back pain, and it does. Your core does the exact same thing, but naturally. Our goal is to build your body's natural back brace to help support all of those discs, all of the bones, all of the joints that we'll talk about that are potential pain generators in your low back. So keeping an active core, stretching, doing yoga, doing exercises that we'll talk about to build the core is a very strong protective factor to keep back pain away and to help back pain should it occur and the protective factors didn't quite do their job. As far as low back anatomy goes, really I think it's easier to start at a zoomed out view and then we'll work into the little more minuscule details. This is the full spine. So think of the skull as being right up here at the top. There is a natural inward curve of the neck, an outward curve of the middle back, and then again an inward curve of the low back before an outward curve of the tailbone. That's the natural way that things work. As folks age and as we lose some of the musculature that helps support that low back, you can begin to have a natural forward lean, and then some folks also have naturally sway back, where their low back is naturally curved a little bit more in than other folks. That's a natural anatomic thing, but it can predispose to certain things, certain pathologies, or certain pain generators that we'll talk about in just a little while. As we start to zoom in closer to the low back, this is a view, obviously, of the side, or from the side, I should say, of the low back. These tan boxes are the vertebrae, or the low back bones. In between those bones are the discs. Whenever someone says, I herniated a disc, I got a bulging disc, my disc is slipped, that's what we're talking about, is the blue disc that sits in between those bones. Those discs are important because they sit right in front of this yellow nerve as it exits and comes down the legs. So if there is something wrong with that disc, if it's bulging out, if it's causing any impingement or pinching back here, that's going to cause low back pain especially, but also that radicular pain or pain down the legs like we were talking about. Back here are the facet joints. Those are the joints between the backbones. We'll take a look at those in greater detail shortly, but those are where the backbones articulate with each other, and another, in my world, very common cause of the axial, or just low back pain, not the radicular or leg pain sciatica as well. Last thing is back here. We'll look in more detail at the ligaments in just a minute, but this is called the interspinous ligament, and that ligament is something that we take a look at whenever we look at our imaging. This is the same side cut, but now we get a little more granular again. On the left side here is a cut straight through like so, looking down on the back like rings on a tree stump, is what I always tell my patients. This is called the axial cut. The reason that this is an important view is because we get more detail of this disc. There are two parts to the disc. An outer ring called the annulus. It's really like fibrous. It's like a connective tissue. The inside is called the nucleus. So if you think of the disc like a jelly donut, the outside annulus is the dough of the donut. The inside nucleus is the jelly. When we talk about herniations, the jelly gets squeezed out of that donut, and we'll show examples of that in just a minute. But those are the really important things, and you can see just how close they run with both the spinal nerve exiting here and the spinal canal, where the spinal cord runs in the middle, but where it puts off those nerves. The most common thing in young folks especially, but the most common cause of low back pain is the muscles. Muscular strains, lumbar strains, pulled muscles. These are the more support muscles of the low back that we're looking at here. All of these run up right along the spinal bones, the vertebrae, and that's what builds that support system that we were talking about. The keeping active is going to build up these muscles and prevent any, or at least try to prevent, those discs and those bones taking the brunt of all of our walking, of any high impact that we take. It's going to help build that support system, or the back brace, the body's natural back brace, like we talked about. Everything's connected. PM&R is a very biomechanical field, so my specialty is a very biomechanical field. To me, this is a much more important picture than those nitty-gritty detail of the low back, because this is all connected. If you have weak low back muscles, like the lat, this muscle here that runs right across like so, it will cause extra stress on the rest of the back muscles. So whenever you see someone that comes in and says, oh my gosh, I started to have low back pain 5 years ago, and now I have neck pain, I say, well, that makes sense. If we take care of one of those things, oftentimes, and work on building the muscles and doing all the things that are preventative, oftentimes it will take care of both. That's my goal as far as the PM&R perspective goes. The other thing that's associated here is the glute muscles, your butt muscles. So those muscles are, again, associated with all of this chain of muscles that help support your body being upright. As the glutes end, we get our hamstrings. I have back pain. I'm preaching to myself here as well. But when your hamstrings are tight, it is going to create extra stress on your backside. And when that extra stress sets in on your backside, it will create extra stress on your low back. Everything is connected. Keeping loose, keeping strong is our absolute best way to prevent and treat, eventually, this low back. This is a little more of a medical school picture, but I do want to show it to you because there are a couple of very important ligaments that we're looking at here. This PLL between the red and the blue line is called the posterior ligament. That is what protects the back canal, so the spinal canal, from any discs that are coming out. It helps hold it all in together. The ligament back here is called the interspinous ligament. That ligament runs between the backbones that you can feel in your back. Those are called the spinous processes. So it runs between those, and if it gets inflamed, it can cause that very midline low back pain. Above that's just the supraspinous ligament here, but that's not one that we typically look at quite as much as a pain generator. So we know the anatomy. Now, how do we get to see it in our patients? The low back x-ray is kind of our first line of imaging. It's very quick. It's very affordable, to be frank. Everything comes down to dollar and cents at some point. And it's the first thing that our insurance companies want us to get whenever we get a low back patient. I do have to practice some insurance. I prefer to practice medicine, but insurance tells me a little bit of what I have to do. But the x-ray is a very useful type of imaging for us. As you can see, we have our boxes here, the vertebrae that we saw in the other pictures. The discs sit in between those vertebrae and between those backbones. Unfortunately, on an x-ray, because they're soft tissue, we can't see those. Back here in these circles are where the nerves exit. So if there were to be like a disc herniation coming out there, or a bulging disc, we wouldn't be able to see it quite as well on this, except for some wear and tear or some shortening of the discs in between those boxes. A CAT scan is the next most detailed that we typically use. If you go to the ER and say, oh my gosh, my back hurts, this is typically the imaging that they'll get because it gives us a really good view of the bones. The ER's job is to make sure that the patient doesn't need to be admitted and that they are safe for follow-up. So if there is a big fracture in your back, it would show up wonderfully on the CAT scan. It's also an option if you're not allowed to get MRIs due to pacemaker, stimulators, or what may have you. This is another really good option for us to get because it won't cause any trouble with those. The last thing that can get us a CAT scan, or get a good thing about a CAT scan, is that it gives us 3 different images. This is that cut through the back, where we could see that bone and the spinal canal really nicely. This is the cut, just like so, looking at you from the side, just like the x-ray kind of looked like. And then this is a cut straight through you, looking at you from the front. So it gives us 3 really nice planes to look at for all of our imaging. The end-all be-all for my clinic, though, is looking at this MRI. The MRI has the same idea, except this patient's facing the other way. The boxes are those vertebrae, but you can see the discs really nicely whenever we get an MRI of the low back. We also get the same 2 cuts. We don't get the front to back cut, but we get the same 2 cuts here. So we can see these nerves exit on either side here and here. The other thing that we can see are those facet joints, or the joints between the backbones that I talked about. They look really nice on that cut straight through, rather than the cut from the side, like so. This is basically a little tough to read, but a labeling of all of the different structures in the back. You have the 5 lumbar vertebrae, the 5 backbones back there, the tailbones down here, and then this is that spinal canal where we're looking at the nerves here, and the white stuff is spinal fluid. So this is a pretty healthy looking back. This cut through obviously has a lot more detail and a lot more structures that we're worried about. Back here, though, are what I want to focus on, and up here. Those are the muscles that I was talking about needing to build up, those paraspinal muscles. And this looks like a really healthy paraspinal muscle. There's also the iliac crest. So you can see the iliac crest is the big part of the pelvis that we can look at as we look here. So, to the nitty-gritty, so now we're done with the nitty-gritty, to the stuff that we really want to talk about. What goes wrong with the back, and what causes the pain that so many folks, 8 out of 10 folks in their lifetime, will deal with. This is a very broad kind of general overview of different disc types that can cause pain. The top here is obviously the normal disc. It looks like it's got good height. It can start to degenerate. When it degenerates, it starts to lose some of that connective tissue, that annulus or the dough of the jelly donut. As that gets weaker, it starts to bulge out. The pressure of the jelly starts to push the tissue out back towards where those nerves exit in the spinal canal. If the jelly gets squeezed out of the donut, so if the nucleus comes out through the connective tissue, that's called a herniation, and that can cause a lot of pain, especially down the leg. If it is just wearing out over the course of time, it will usually start to look like the second 2 down here. There is a thinning disc, which is just degeneration or arthritis, and then there is degeneration with osteophyte formation. Osteophytes mean bone spurs. In my world, typically those bone spurs are a sign of chronic inflammation. So we see bone spurs that build all the way out and actually connect with the bone below or above the backbones. That's just a sign to me that the patient, or whoever I'm seeing, has a lot of inflammation and has some instability in their back, typically. This is kind of my baseline picture of a healthy looking disc. The inside, the bright yellow, is the jelly. The outside, the AF, is that annulus, or the dough. The main thing, the most common thing in my world that we see with those discs is bulging. There are a few different ways that it bulges. If you have pain on the right side going down the right leg, but the left side's great, we're usually looking at something like this asymmetric bulging. It doesn't mean it's always going to spread out the same way. It will spread to one side or the other. Some folks do get just diffuse bulging, which means it's pretty equal on both sides, or at least there is significant bulging on both sides. The different types of discs that we see are kind of shown here. The top one is that bulging disc. It looks like it is well maintained. So all of the structures are still in place, but they're squishing down, and that disc is bulging out. When the disc loses its structure and that jelly comes out, that's when we talk about a herniation. And that's a pretty subtle one. We'll look at one that's a little more dramatic later. The next thing that we see are disc tears. So that is when the dough has torn but it hasn't allowed the jelly to come all the way out of the donut. The tear that we're looking at here is at L5S1, so the very bottom disc, and it's just this little bright dot. That bright dot is a sign of a tear. The tear can portend future herniations because now you've started to lose a little bit of your dough. Lose a little bit of your dough. As that tear progresses, it may allow for the structural components of the disc to lose themselves and get blown out, basically. This is the picture that I think shows what a herniation looks like the best. And what we're worried about with the herniation is compression of that nerve root as it exits and causing that pain, weakness, numbness, all of the things that we see with a pinched nerve going down the leg and sciatica. This is the much more dramatic picture. This is the one that I don't want to see in my clinic. You can see this herniation has come all the way out, and on our axial cut, that's straight through the belly cut, you can see it's coming out and really pinching the nerve as it exits here when you compare it to the other side. So this would be a pretty severe left-sided pain if I had to guess whenever I saw the imaging. These are the different types of disc pathologies that we see oftentimes. The one thing that I do want to point out here is the difference in verbiage amongst different people. I've seen people call a disc bulge a herniation. I've seen people call a disc herniation a disc protrusion. I've seen a disc extrusion called a sequestration. All of that means that really talking to your doctor, looking at those pictures together and explaining, getting an explanation from the doctor, and I'm maybe trying to build some job security here, but if you guys really take a look at it with your doctor, it goes a long way in explaining, hey, here is exactly what's going on, rather than reading that MRI report that comes through my chart and it says that your back is basically falling off and now you need to go to the doctor immediately. It's always scarier. It's never as scary as it sounds. It's always scarier in words than it is in pictures in my life for the most part. The last thing that we'll look at with our discs is a slipped disc. So this is something called listhesis. Basically, the disc has lost its structural integrity, and by losing its structural integrity, it has now allowed the bone to slip on top of the one below it. That can cause, essentially, a kinked spinal nerve. If it gets bad enough, it can cause pinched nerves affecting basically every downstream nerve. So if you had a big slipped disc at L3-4, it could affect this one, all of the bottom ones. It can really cause some pretty significant downstream effects from those pinched nerves. We see about this level fairly frequently, and that doesn't mean that you are going to have a spinal cord injury if you have a slipped disc. A lot of folks are totally asymptomatic from their slipped disc. It's just something that we have to be wary of and be cognizant of whenever we're treating these types of backs. The last one that we'll look at, and Dr. Chen's team will look at this a little bit more, fractures. Compression fractures are the most common one that I see in my clinic since I'm an outpatient. You can see in this picture, instead of having a nice happy box like so and like so, we've got a wedge or a slight dip in the L1, in this case, the middle backbone. That is due to high load as you walk, as you cough, as you sneeze, as you roll over in bed. Any of those things can cause this. Basically, it's really hard to predict, and we see these as asymptomatic. I'll tell you, my dad got diagnosed with one, and he didn't have back pain at all. We also see people who come in and are in excruciating pain, can't walk because of the severity of this. Everything's a spectrum with back pain, and the pictures rarely match exactly the symptoms. It's one of those things that we're putting a puzzle together. The main risk factors for this are the osteoporosis, because as you get more brittle bone there, it's going to be able to take less stress and less stress and less stress before it says, hey, I'm out. I'm going to crunch down here and try to compress myself to make myself stronger. These are a little more granular than I think we probably need to get into, but I felt like I needed to at least show. If you come to me and I see any of these big translational injuries, something has gone awry in our diagnostic process and someone should have sent you to the ER much sooner than you got to see me. These are very rare in my world because they're very rarely atraumatic, not anything that we really need to worry about. But it does show on this left side, there are grades to how much compression we get. It can go anything from a box being like so to completely flat. It all just depends on the level of thin bones and the level of trauma or the level of pressure that we're putting on the back. So everything is a spectrum. Just like I said, those compression fractures will fall in the same kind of category. The facet joints. This is one of the things that I think is really a common pain generator. The joints are like any other joints in your body. Your knee can get arthritis, your hip can get arthritis, your back can get arthritis. The discs and the facets are both symptoms or targets, I should say, of that back arthritis. You can see in this picture the discs up in front and the facets in the back kind of form a trio. If the disc is really happy and healthy and say yay big, the facets sitting behind it are going to have good support. They're not going to be taking too much stress because the disc is taking a lot of the stress off of them. As the disc wears down, those facets start to ride down as well. They start to get more and more and more pressure. So as we get degenerative disc disease, that can cause pain, but it also predisposes you to facet joint pain because they are a team. You lose one, you're going to end up dealing with some extra stress on the others. This is an MRI where we can see the facet joints on either side here. There are two types of pictures that we see with facet joints. One, and on your left side here, you can see, is called gapping. That is where the facet joint's too big. There's too much fluid in that facet joint. I kind of liken it to having an effusion or a swelling of fluid on the knee whenever you have a bad knee arthritis where they go in and pull the fluid off the knee. This is a similar type deal, but it's a sign of instability. So there might be some sliding of that disc that's leading to that extra space. On the opposite side here is more of your garden variety arthritis. So that arthritis is a too little fluid in the facet joint. This one's not severe, but I just wanted to get one picture that tried to show both of the things that we see with facet joint arthropathy or arthritis. The last one that we'll look at really in depth is the SI joint or the sacroiliac joint. Sacro means tailbone. Iliac is part of the pelvis, the iliac crest there. There is a joint between them right here and right here. It's a big U-shaped joint because the sacrum, it's a big kind of area for those two to connect. But one of the big things that we see is anyone that's had lower back fusion or hip replacements, oftentimes the brunt of the blow starts to sit on that SI joint. A lot of sit to stand pain is common with this. Walking pain can be common with this because if you think about the mechanics of the body, when you're standing just like so, it is putting pressure on those facet joints and it's putting pressure on those SI joints. I'll tell you, I have to warn a lot of my patients that SI joints and facet joints love to masquerade as each other. There are certain diagnostics that we can do, like the MRI, like my clinical testing, physical exam, all of the fun things that we get to go through. But also, we may need to do diagnostic injections. So that is something that we may have to do a little trial and error, or a fact-finding mission is what I like to say, because I don't like to say error whenever I'm putting needles in people's back. But that is something that we may have to do to figure out and suss out the primary pain generator. The spinous processes, those bones that you can feel between the backbones, that interspinous ligament that I pointed out earlier, if those spinous processes get too close together, it's something called kissing spine disease, and that can cause a lot of pain right in that middle line. You can understand why they called it kissing spine, because you can see these guys are really bumped up right up against each other. Can cause a lot of pain exactly in the midline. I don't usually see folks that have it on either side. It's just dead line in the middle, and worse with leaning back, because that's going to close down those bones and create extra stress on them. So what do we do about it? The best way to treat back pain is to prevent it. That's the goal always, and that's what I try to tell folks. If they're coming in with an acute back pain, I don't say, hey, this is going to get better, you don't need to do anything. I say, hey, this will hopefully continue to get better, but here is how we prevent it from happening again or becoming chronic. So, exercising, keeping active, and specifically these types of exercises, you can see, I talked about the hamstring causing back pain. The number one thing that we have up here is that hamstring stretch. Working on those back muscles, working on the pelvic muscles, and then working on the abdominal muscles. So if you strengthen the back, you also want to strengthen the front. Everything in balance. That's what we want. Same thing with strengthening the front and strengthening the back here. We want everything in balance to prevent it coming forward or going too far back, losing that natural upright that we have. So when we work on our low back, we also work on our abdomen here. A lot of the side muscles are done with this kind of side plank that obviously if you come to my clinic, a lot of folks get a handout that looks exactly like this because this is what we want folks to do. If the patient doesn't feel comfortable doing these on their own, or if I feel like they need a little more guided exercise, our next option is physical therapy. Very few people come through my clinic that don't at least get to see a therapist once because they get to spend hours with you. In our clinic, we get to spend minutes. So they get to tailor an exercise program specifically to your back and to your ability level and to your safety level. We want to make sure we're not doing those standing hamstrings and fall. We want to make sure that we're not going to do any extra undue stress on any surgeries we've had, or if we have a lot of osteoporosis, we don't want to put extra stress on those midline bones as well. So guided physical therapy is really, really beneficial for nearly all back pain patients in my world. Then there's the pills. There is no such thing as a great back pain medicine. There are ones that do good things along with being bad, but there is no magic bullet for this. Everyone wants that quick and easy fix. I would too, and I took gabapentin whenever I had my bad back pain. I cannot practice what I preach, that there's no good medicine for this, because it can help. There are really kind of 6, 7 common types of medication for low back pain. NSAIDs are non-steroidal anti-inflammatory drugs. When you think of your Motrins, your ibuprofens, your Aleve, your Advils, your naproxens, all of those over-the-counters that don't follow with Tylenol and aren't topical really fall into the NSAID category. Good is that they calm down inflammation. It's really a powerful drug for this. Bad, they will hurt your kidneys and they will hurt your stomach over time if you don't take them sparingly or don't take them as needed. If you take them daily or every 8 hours or take too high of a dose, they can cause all the way up to like GI bleeds and kidney disease. So it's an acute drug. It's a drug for when that pain is bad. Tylenol, acetaminophen is the generic name for that. So that is shown to be as effective as any other medicine, including opioids, when it's on a blinded study. I can say that until I'm blue in the face, and I don't think people care. But it is shown by the data to be just as effective for that type of pain over the long term. Muscle relaxers, there are a few that fall into that category. Flexeril, Robaxin, and Tizanidine or Xanaflex are the most common ones that we see. That is for spasms or cramping. So if you have an irritated nerve coming out and down the back, you can start to have cramps because those nerves don't know what to send to the muscles, and the muscles don't know how to respond to the signals that they're getting from the nerves. So that can lead to cramps. Muscle relaxers will help with that. It also helps with that really severe muscle tightness that can come from inflammation in the low back. Gabapentin and pregabalin are one of the most common medicines that I use in my clinic. They are specifically for nerve pain. So if you say, I just hurt right across my back here, that's kind of it, usually we won't use one of those medicines. If you say, oh my gosh, my sciatica is killing me, gabapentin and pregabalin are one of the things that we like to do. The good of both the muscle relaxers and the gabapentin pregabalin is that they are targeted for kind of one specific symptom. Our goal is to treat, and they're really effective at treating that one specific symptom. The bad of both of them is they are sedating. So we have people who take the lowest dose of gabapentin and they wake up the next morning. They only take it nightly. They still wake up the next morning feeling like a zombie. We have people who take muscle relaxers. One good thing is a lot of my patients can't sleep because of their pain, and they say, well, at least the Flexeril knocks me out. They do increase the risk of falls in people over 65. There is a criteria that we have to follow, and that means it is not a one-size-fits-all. None of these medicines are, again, a perfect drug. Cymbalta and amitriptyline are originally targeted as antidepressants, but we found out that they're actually more effective for general diffuse pain. So if you come in and say, hey, my neck, my knee, my low back, my backside, and my foot hurt, you might get Cymbalta from me. You might have earned a duloxetine prescription. Steroids are my primary thing that I inject rather than do orally, but oral steroids are an option. The good of those is that they are a potent anti-inflammatory. The bad is you don't sleep, you eat a bunch, it can make you swell, it can raise your blood sugars, it can raise your blood pressures. The list goes on and on. Long-term steroids for my type of back pain are very rarely a good option. But if they're targeted, that's my whole thing. I'm an interventional pain doctor. My interventions a lot of the time mean steroid injections. Last is opioids. Those are indicated for severe acute pain. Rarely will we prescribe them from my clinic because I'm seeing people for follow-up. I'm seeing people who have already seen someone to get referred to me. If they are at the point where they need opioids from me, most of the time it will either need to be to a pain management doctor, like a medical pain management doctor, to our surgeons, or to the ER, because that's the level of pain that I think opioids typically are warranted for. The kind of main thing that I do are back injections. So there are three types of approach that we do for an epidural. One is up the tailbone. That's this caudal approach. We go right up and inject around the nerve roots in the tailbone. The other is what I call my carpet bomb approach. That's between the backbones that you can feel in your back. The other is a more stealth bomb approach. That's around the nerve root as it exits, those yellow nerve roots that we saw the disc can bump up against. We want to get the medicine right where that disc is bumping up against it and causing the pain down the leg. This is what the pictures look like. This is what I look at all day on Mondays and Tuesdays in North Tower. So this is that targeted approach coming in from the side. This is where the nerve exits, right here. So we get the needle right there, and we inject right around that nerve root specifically with the intention of coating it as best we can and as targeted as we can. This is the more carpet bomb approach. We get in between those bones, and I inject the medicine right here with the intention of coating this whole area, at least 2 levels up and a level or 2 down, with all the medicine that we can to try to basically cover everything as best we can. That's good for both sides, back pain, pain that doesn't really follow one nerve root, or a back that just doesn't have a disc that I say that's the troublemaker. Last one's the caudal, that up the tailbone injection. The good one about this is for the more like wrap around the groin pain, or if we feel like someone's had surgery at a level and we can't do an injection there, this is a pretty safe one where we can really flood the area as well. The last one that we do that I wanted to talk about is the RFA, or the radio frequency ablation. Most people that I see in my clinic say, oh yeah, I had a friend tell me about the ablation. Is that an option for me? And it all depends on the pain generator. If we think those joints, the facet joints that we talked about, are your pain generator, then this is a potential option. It is more of a process. It's a series of 3 injections that we have to do, but we hope to get 6 months to a year of really good relief out of the RFA. There's always risks and benefits associated with this. That's a little more granular than I think we need to get today, but it is a very effective treatment for folks. The compression fracture that we saw earlier has a couple of options as well. Medications allow it to heal itself. Typically, if you have a compression fracture, we'll look at 3 months of healing. If you're someone who walks around and say, yeah, my back kind of hurts, I'll say, let's give it 3 months. If you're someone who comes in a wheelchair because of the severity of the pain, we'll likely send you to our guys who do what's called a kyphoplasty. That is where they go in and basically pump superglue cement into the bone that's compressed. I hear the groans. It is not as horrible as it sounds, but it is a fairly effective treatment for that compression fracture pain. Good is, it works pretty immediately for a lot of people. Bad is, it puts you at risk for further compression fractures, especially if we're osteoporotic, because now, instead of having some soft bone to bump up against, you got cement. So you get your cement right here, this bone and this bone are now hitting the pavement. So that's not exactly what we want for potential long-term. Last thing that I'll hit on today is outcomes. A vast majority of people that have low back pain will get better within 6 months. A pretty great number will get better even quicker than that. But 6 months is what we typically see for resolution, or at least diminishment to the point of being able to be functional, being able to do what you like. The reason I'm here is to try to, 1, make it faster, and 2, make it feel better while we allow your body to heal itself. There are kind of 3 baskets that people fall into with those disc herniations that we saw. One, the disc herniation will actually improve. The MRI will look prettier the next time you get it because the body can have an immune reaction to the disc and eat away. Basically, it sends in special cells that eat away at the disc herniation. Number two is the picture stays the same. It's an ugly picture, but it doesn't hurt. So we don't care about an ugly picture as long as it doesn't hurt you. And then number three is picture stays the same, pain stays the same. That's usually when folks end up in my office, either for the long term or with our neurosurgery friends. The thing that I want to show here is the pain score out of 100 is on this up and down axis, the y-axis, and then the pain in weeks since it started is on this bottom. So you can see at the initial, we're up at like 70 on a scale to 100 to, up to 100. So a 7 out of 10 on the pain scale in our world. By 6 months, a vast majority of people are way down here at that 15 or so. And this was without intervention. This was without any treatment at that point. There is improvement as we go further with the scale going all the way out to about a year here, and it continues to increase, but the huge number of people, it will drop within that first 3 months or so. The persistent low back pain is one that's a little more tricky. That's the folks who see me most of the time. So sorry, this top one was acute low back pain. The bottom one is persistent. You can see still over the course of time, it does improve, but we definitely don't have that same sharp drop and then a little leveling. It's just kind of a slow improvement. And that also is without treatment. This is more of a disability rating, and it basically shows the same thing. We see folks who have an acute disabling low back pain, like a compression fracture, like a herniated disc, like a severe muscle strain. They improve over the course of time. So there is hope. Whenever you have back pain, don't wave the white flag. Don't just immediately give up. Keep active, keep mobile, and hey, potentially come see me. Hopefully I can get you some relief. So thank you guys for your attention. I will now open up the floor to questions.
All right, who's got questions? All right, I'm trying to go back there. I'm gonna start with you because it's a little easier to get to. My question is, what if you've been diagnosed with spinal stenosis? That's when I believe there's like extra bone growth at the point of stress rather than compromised disc growth.
Yeah, so spinal stenosis means, I'm going to bring up my MRI here because this will be useful the rest of the time. So spinal stenosis means tightening of basically the sac or the straw that holds the spinal canal. That can be due to bony overgrowth. That can be due to disc bulging. That can be due to overgrowth of the ligaments behind the spinal canal, most commonly a combination of everything. The treatment for spinal stenosis is a tough one. There are a few minimally invasive treatments that are emerging to treat spinal stenosis, but the true fix is usually going to be our friends, once it's severe enough, is going to be with neurosurgery. If it's mild, moderate, even some folks with severe spinal stenosis respond very well to injections and respond very well to therapy, the things that we can do that are less invasive and less risky. There are always risks incurred whenever we start doing things that are a little more invasive.
Any more questions over here in this group? Okay, come to the back.
I'm trying to pick out from the menu that you have offered. I have pain management, I have the spine center, and I have you guys as well, orthopedics. And there are times when I call the orthopedic clinic, I've been referred to you guys, and I'm very happy with the medical care that I get. But how do I navigate which one of the services I need to pick out to help me manage what's going on with my diet?
So I serve in the PM&R department. We are part of the Comprehensive Spine Center. So the ortho guys, Dr. Decker primarily, will get the referral. Sometimes he'll take a look at it and say, not a surgical back, go to the Comp Spine Center. Usually we are somewhat of a gatekeeper. We'll take a look at you first and say, hey, this is what's going on. This is what we think we need to do. Because last thing you want to do is start with surgery. Trying all those minimally invasive things, trying all of those non-invasive things is what we certainly want to try before we go anything as drastic as surgery. So Myself, as PM&R, we have providers that are spine, and then anesthesia pain also has providers who are spine. We cross over a fair bit. I will tell anyone who has seen anesthesia pain or myself that if you go see the other one, it will be a fairly similar visit. We just come at it from a slightly different angle. PM&R, we do a lot more of those biomechanics where everything is connected, where we try to focus a little more on the things that led to this, the things that potentially will exacerbate or relieve it, rather than straight interventions. But the anesthesia pain guys also have some things that are minimally invasive. Like I was saying, they can do some things. And if you say, I am not getting a needle in my back without sedation, then they're your guys. So I get it, I hear you, but we just can't do sedation in my department. So we cross over a good bit, but if you do comprehensive spine, it comes through our office often.
Question? Yeah, two questions. One, and this may be for you. Is it possible to stream your presentation, which is very good?
Thank you.
Review for later? Yes, we'll send it out after this. Okay, great. And how does a genetic condition like scoliosis impact back pain, and does scoliosis get worse?
So scoliosis will predispose somewhat to back pain. So if you think of our x-ray, or we'll look at our CT scan here. So if you start to have a bend like so, it is going to close down those facet joints, the joints that we talked about that can cause the back pain. It's also going to tighten the canal as those nerves exit. So that will increase the risk of back pain. Scoliosis is something that we emphasize and emphasize and emphasize. Please keep active because you are naturally predisposed as gravity takes its effect to bend and bend and bend and bend. The only way to prevent that worsening is to increase the strength of the muscles that help support it. There are a few other things that can happen with scoliosis, like ribs against pelvis and things like that, but for the back pain, that's really the primary troublemaker that I see, as well as biomechanical issues. So if I am leaning like so, this muscle on my right side, your left, is getting stretched, and this muscle is constantly contracting. It's going to create an imbalance in those muscles, and it's going to create an imbalance in the pelvis as well. So now we're creating a bunch of different imbalances and a bunch of biomechanical issues that can predispose to pain as well.
More questions? There's one up front there.
Thank you. When we do the bone density testing, they do it in terms of T-score, -2, -3, and so on. And it gives a recommendation or a warning that within 10 years there will be a fracture. So at what T-score level is the fracture actually going to happen? I know it is something that you cannot predict. And what kind of activity will cause pressure to increase and cause fracture in the spinal column?
So, of course, I will defer numero uno to the next lecturers because they are a little more focused on that T and Z score. The tough answer is coughing, sneezing, and having a bowel movement. Increase the pressure on that spinal column as much as just about anything that we see folks do on a day-to-day basis. If you're jumping off ladders, if you're jumping out of helicopters, if you are doing skydiving, all of those things, sure, high-risk activities are high-risk activities. But for the most part, anything that is weight-bearing and low impact will help build the bone and the muscle. Anything that is super high impact will put you at a higher risk. The main thing that we focus on is form. So I see people all the time who, instead of doing the leg, bend, lift, they come into me because they did exactly this with a bag of cement. There you go. I mean, one thing follows the other here. And that's the primary thing that we talk about, is trying to avoid those super high impact and trying to avoid bad form. But really, natural things will cause increase in the spinal pressure, or the spinal column pressure.
Hi, you didn't mention a word that I've come across. Does collagen play a part in any of this?
So collagen is one of the things in the disc. It is connective tissue in the disc. As collagen deteriorates, you end up with those tears and those herniations. Yes, ma'am?
If you take collagen supplements, does that help?
So the data behind it is up and down. The quality of the supplement is also up and down. A lot of these supplements are not subject to FDA, so they can say, I could give you a sugar pill, and sure, there's probably some collagen in the wrapping around that sugar tablet, so I could claim a lot of things. So I am not willing to endorse a specific collagen, and I can tell you that the data, there's very little downside, but the data does not give us a lot of upside either, just yet. We got a bunch in the back.
I'll get one right here before you get back there, Sean.
So swimming will be the best exercise for all these impairments.
I love aquatic therapy and I love swimming. Swimming works basically every muscle group in your body, and swimming is no impact. So you are keeping your head up to breathe. That works those back muscles. You're also keeping your core engaged by kicking. So all swimming and aquatic therapy are really the top of the list for me.
I agree. You're supposed to work out the weight room. You're supposed to have your back straight and curls. These other guys would be like this back. I can imagine what they look like now, but the other thing is when you sit down, it's your posture. And at home, we have banking chairs that hold showers that have the resting for your back. It has a lift down on your buttocks. So it kind of forces you to sit up straight and have your back, aligned properly.
Absolutely.
So posture, and like you said, don't bend over with heavy stuff.
Exactly.
All right, this will be our last question, I think. Here.
You have mentioned mostly lifestyle changes to manage the back pain. What about surgery? You did not mention. When do you recommend that?
So that, of course, is our last resort. I didn't mention it because it's certainly not my specialty. So I didn't want to kind of talk about things I didn't know that well, and I know Dr. Chin's following me. It is when we start to have neurologic compromise. So we're having trouble with going to the bathroom. We're having trouble with numbness in the groin. We're having totally debilitating pain. Or we're concerned about those things impending based on the imaging. Usually, we will try all of the things that I mentioned prior to any surgery because it is the most invasive thing we do for the back. And surgery sometimes will lead to more surgery. So if we start that process early, it can lead to more surgery down the road. The surgical option, though, is certainly our last resort. And it is the big scary signs, the incontinence, the numbness in the groin when you wipe in the bathroom, acute weakness, acute pain that is immediate onset, and we look at the MRI and say, oh my gosh, that herniation is smashing that nerve, and we know exactly where the trouble is.